for the CPAN program here at UT Tyler Health Science Center. Thank you for joining us today for our session, Does This Kid Really Have Bipolar Disorder? This is a session that was requested by one of our pediatricians in Northeast Texas, and I appreciate Dr. Blood doing the research and putting together this session to be able to present to you today. We'll be starting here in just a moment, and I do have you all muted during the session. We will be opening it up for questions towards the end of the session. You can also put questions into our chat anytime during the session, and Dr. Blood will get to those towards the end. We will have a Q&A session at that point. So let me tell you a little bit about Dr. Blood here. So Dr. Blood is a physician and a psychiatrist here and a native to rural Northeast Texas. He attended Kansas City University of Medicine and Biosciences, where he received his Doctor of Osteopathic Medicine. After completing medical school, he returned to Texas for his general psychiatry residency at the University of Texas Health Science Center in San Antonio, and then completed his fellowship in child and adolescent psychiatry at the University of Texas Southwestern Medical Center at Dallas, where he was chief fellow. He is currently board certified in the American Board of Psychiatry and Neurology in psychiatry. Dr. Blood joined the UT Tyler Health Science Center in 2020 to be an assistant professor of medicine in the Department of Psychiatry and Behavioral Medicine. He is the medical director for our Northeast Texas CPAN team here at UT Tyler Health Science Center, and as well as the medical director of the UT Health East Texas Lake Street Pediatric Psychiatry Clinic here in Tyler. So I'm going to hand this over to Dr. Blood, allow him to share his screen, and we'll get started.
All right, can you see my slides?
Yes, sir, it's the right screen.
All right. Gotta find where my control window went. There it is. All right. All right, so here's our learning objectives for today. So we're going to define bipolar disorder. Then we're going to differentiate similar symptoms, presentations, and other non-bipolar disorders, and then know what first steps to take when treating children and adolescents with mood disorders. Those are learning objectives for today. Here's the outline. So first, we're going to go over the criteria for bipolar disorder, the epidemiology, prevalence, and bipolar in children and adolescents. What does it look like in real life? Then we're going to talk about those other non-bipolar disorders like dysregulated mood disruptive disorder, what that looks like, and what other conditions can have similar presentations. And then we'll finish with what you as a PCP can do with kids that have a similar presentation to this. All right, so we'll get into the meat of the topic right here. So this is the diagnostic criteria for bipolar disorder. So there's bipolar 1 and 2. So 1, you have to have at least one manic or mixed episode. With bipolar 2, it is a hypomanic episode. All right, and they both have to have a major depressive disorder for that. There's something similar called cyclothymic disorder, which is just several episodes of hypomania, but no full criteria for major depressive disorder. So these are kind of like, they have a lot of these symptoms, but they never meet criteria for any of these things. All right. Then you have substance or medication-induced bipolar-related symptoms that directly relate to a substance that can produce manic symptoms.
Why are you all sleepy? I'm good, thank you.
Oh, somebody is not muted. All right, so here is its clinical presentation. So you have to have a distinct period of persistent, elevated, expansive, and irritable mood and persistently elevated activity or energy lasting at least 4 days. And you have to have three of the following. So an inflated sense of self-esteem or grandiosity, a decreased need for sleep, more talkative, like a pressured speech, flight of ideas or racing thoughts, distractibility, increased goal-directed activity or what we call psychomotor activation, excessive involvement in activities, and there's kind of with a high likelihood of painful consequences. Um, and these are a specific, unequivocal change or that's very uncharacteristic for this individual. So this is clear change. It's definitely observable by others, and it's severe enough to cause a dysfunction or impairment. And of course, it cannot be attributed to a substance or medical uh, treatment. Okay, so these are the defining features. So it's persistent and it lasts for several days, and they have to have enough of these symptoms. Okay, it has to be a change from their baseline. Okay, so those are the big things for a manic episode. All right, this is hypomania now. So a distinct period of persistently elevated, expansive, irritable mood, and so these are the same things. Of at least 4 days, three of the four following. All right, so the same exact things, but the big thing is that it's not causing impairment. So if you look at the bottom, I say not severe enough to cause dysfunction or impairment. So hypomania, you can have these things, but there's not impairing their daily functioning. I have had several encounters with hypomanic people that are really driven, really after it, and they do really well. They're usually really successful people, um, but there's because there's no dysfunction. So they may have this decreased need for sleep, really increased directed activity, um, and some of these other things, but there's no impairment. Okay, so that's the big difference. Okay, of course, and then you have to have a depressive episode as well. So, in a depressive episode, just I know we've covered this in many other presentations, but it's at least five of the following present for at least a 2 week period. And it has, again, once again, distinct change from their previous functioning or their baseline. So, depressed mood, often in children, you're going to see an irritable mood, marked decrease in interest or pleasure. That's what this anhedonia is. Guilt or worthlessness, fatigue, loss of energy, diminished concentration, and their appetite can go either opposite, it can go increased or decreased, but it's got to be a change, right? And then there's either psychomotor agitation or retardation. So either they're very restless or they're very lethargic looking. And then recurrent thoughts of death or suicide. And once again, this causes distress and impairs their functioning. And of course, once again, not attributed to a substance or a medical condition. Okay. So those are the main criteria for bipolar. You have to have a manic and a depressive episode. All right. So what about if they have like a mixed feature? So yes, there is a subset of mixed feature, and that is the coexistence of depressive and sorry, I can't even talk today. Coexistence of depressive and manic symptoms mixed all together. So they get this, there's basically this mixture of them all. In these episodes, but they still have to meet criteria for the mania or hypomania and major depressive episode. Okay. Um, so these are just diagnostic criteria. That's I wouldn't really worry about this one because the whole point is this presentation is does this patient or does this kid have bipolar? All right, so that was the clinical diagnostic um, of bipolar. So how often does this happen? So back in 2011, big meta-analysis of a dozen epidemiological surveys suggests that the global community prevalence of of bipolar disorder is 1.8%. And that's been pretty on par for what previous data had showed as well. Later, this was updated 2019 to 3.9%. But then, after they did some scrutiny of that additional surveys, they actually found that it was unsuitable for statistical meta-analysis and warranted narrative analysis. So then they went back down to the 1.8%. And this is, remember, this is global, okay? And this was off of a 9-article debate that they were making this criteria or making this judgment call, okay? So it is a relatively low percentage disorder, okay? That's kind of the point I was trying to make with this. All right, so here's a comparison of adolescents versus adults. So it's roughly about the same, 2.9, 2.8. Females in adolescents, they have a higher percentage than males. Not quite, it's more 50-50 in adults. As you can see, 2.8, 2.9. All right, and then here's the biggest thing that I want to show this slide is the impairment. Only 2.6% of adolescents diagnosed with bipolar had a significant or severe impairment. But what about adults? 82.9. So that is a huge difference going from 2.6 to 82.9. All right, so this is where I start questioning diagnosis of, does this kid really have bipolar? If they're not having an impairment, that is that's what makes a disorder, right? Is impairment. All right. So this all came from the NIMH statistics and health. So this is what makes me wonder when I see that somebody came to me or somebody told me that they have bipolar disorder. All right, here's once again another also from the NIMH. So overall, we still see that it's this 2.9, 2.6 for adolescents, the female rate, and then this just broke it down into age groups. So the younger they are, the less likely they are to get this diagnosis. All right. That's the whole point of this slide is kind of showing the age. The younger they are, the less likely that it's going to happen. All right, so what does this look like? This is kind of what we're going after, right? So there's these mood swings, and they have to last for a distinct period of time. There's not a going from happy to angry immediately, and that's what is bipolar. Somebody just, oh, they're just angry. And the kind of common vernacular in the community is, oh, they have bipolar. That's not really what it is. Has to last for that distinct period, like we talked about, and it greatly affects our actions. So there can be hyperactivity, impulsivity, aggression, in social aspects or in other areas of their life. Get these racing thoughts. They're quick to change subjects. They're just kind of talking at 90 miles an hour. You can't get in a word otherwise. So this is what that would look like. They get risky or reckless behavior, something that's very out of character for them, right? Um, Sometimes in kids, it may be hard to see this because they all kind of risky, right? Um, so what are some of the common things that we see is spending more money. In older teens, it probably really be the increased sex or multiple partners. It's hard for them to go on spending sprees because a lot of them don't have any money, but they may just be wanting to spend way more, keep asking their parents for more and more money, things like that. Okay, or sneaking out more, more likely to use or abuse substances during that specific episode. All right. As far as their sleep, it is a decreased need for sleep. They'll start staying up later, waking up earlier, and being just fine. They'll still have tons and tons of energy, you know. Um, that disconcordance between not getting enough sleep and feeling fatigued, they will not get enough sleep and still have plenty of energy. All right. They will also have an inflated view of their capabilities. They'll think that they are the best person on the team, that they can now do anything that they set their mind to. They're going to start shooting to get into colleges that they've never even talked about before. They're going to start getting into some kind of program that is like nothing they've ever had aspirations to do before. That's something that's like maybe really hard to get into, you know? Um, so those kind of that inflated self-esteem. All right. They can also, when things start spiraling, you can have suicidal thoughts or behaviors. Um, so that is another possibility during these episodes. And then really what kind of boils down is this isn't their normal, this isn't their baseline. So they've kind of lost contact with reality. Um, I want to say the most interesting case I saw was an adult, and it was very early in my training. Um, Patient is admitted to the inpatient psych unit, and she is on a mission. She has to get down into to the sewers to defuse some kind of bomb that's going to save the city. She was set on this 100%. We couldn't change her mind. And that was her thing at the beginning of admission. Luckily, she improved after a few days of treatment and was doing much better. So these very bizarre things can happen as well. They really can lose contact with reality. Like who would really think that you, a non-police or federal agent, is needing to save the city, right? So, oh, another thing that's not on here that I've actually recently run into since making these slides is I have a team that's becoming more hyper religious, and it's not his normal. He is religious person, but he's become almost all that he now talks about. So you can get it, and that's a common theme as well as hyper religiosity. So it's got to be out of character. So knowing that he was, it made it initially hard to gauge if it was or wasn't. But this was definitely over the top. He was out trying to save people. And things like that that were just not characteristic of him. All right, we've talked about this before, but let's just cover it to make sure. So, what does depression look like? Frequent and unprovoked sadness, this significant increase in irritability and anger. They don't want to be messed with. They leads to isolation. Um, they're hostile when anybody tries to kind of talk to them about anything, whether it's just say, "Hey, come out, join the family." They get very irritable over that. They can get lots of physical or somatic complaints. It usually is increased sleep. Now, it can go to less sleep, um, but often it is increased sleeping. They're sleeping all the time. Um, it's going to be hard for them to concentrate. They start feeling hopeless and worthless. The relationships start to decline. They just start losing friends. They're not spending time with friends anymore. They just don't want to hang out with them anymore. That's what it's kind of looking like. The appetite can go either way. They're eating too much or they've completely lost their appetite. Low energy, a loss of interest in their normal activities. They used to like to do this all the time and now they just don't want to do anything. All right. And then it's frequently they do get thoughts of suicide or death or wanting to harm themselves. So that's what it looks like in children and adolescents. All right, so I wanted to bring up an actual case report of of a younger child. So this is an 11-year-old. Her name is Memory. She lives with her mother and her 15-year-old sister, and then grandparents. Now, according to her parents, she'd always been a cheerful, friendly girl, went out of her way. She had friends in the school and in the neighborhood. But 2 years ago, the family had moved to another city, and it reports that 3 to 4 months now past or at the point of the initial presentation that her mood had changed. She was elated, she was unrestrainable, often laughing without apparent cause. A school was making comments and giving the family notes. She was acting foolish. She kept getting sent out of class. She was having inappropriate behavior. She was having accelerated or what we call pressured speech. She was jump topics, and made it difficult for people to kind of keep up with her conversation. Memory's mother shared that over the recent months that she was energetic and difficult to put to bed evening before that she would usually fall asleep only for 4 to 6 hours, but then wake up energetic, active, without signs of fatigue during the day. Her behavior became sexually colored, flirting with farm employees and things like that. So definitely a clear change from her baseline. So we're seeing a lot of these manic symptoms, right? All right. But she had, on evaluation, she had suffered 2 depressive episodes in the past. The first was a 9-month episode at age 6, and then a second 6-month episode at age 8. So now she's presenting with manic symptoms, and then she also has a history of depressive episodes. All right. So there's the described manic symptoms. So and she's had around 10 episodic anxiety attacks over this last 8 months as well. Each are sudden, unprovoked, and continue for 10 to 30 minutes. Over the last 4 years, the symptoms of generalized anxiety disorder were also observed. So she had a comorbid anxiety condition as well. So, but Emery's mom was stressed out more than was about this anxiety and previous depression episodes. It was all about this change in her behavior, right? Um, so she also noted that she had ADHD. She had inattentive, difficulty concentrating on certain tasks, and this was more long-standing. Okay. So she had met criteria for ADHD as well. So now we're talking, she has ADHD, she has generalized anxiety disorder, she has depression, and now she's having these symptoms. So this is kind of a lot going on with one little 11-year-old, right? So she met diagnostic criteria for bipolar 1 disorder. She had enough of those symptoms to meet criteria, to meet a manic episode, right? And then she also had ADHD, GAD. She also met criteria for panic disorder and separation disorder. Case report didn't really go into the anxiety much because it's all about the bipolar. All right. So, comorbid conditions. So, bipolar youth tend to suffer from anxiety disorders at a rate of 54%, ADHD at 48%, disruptive behaviors at 31%, and substance use disorder at 31%. So those are a lot's going on, right? When with the youth with bipolar disorder. And so ADHD and anxiety, comorbidly in pediatric patients negatively affect all these symptoms. It can be sometimes really hard to 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 see what they really have. So going back to Memory's initial presentation, she had all these symptoms of mania. So she really did meet criteria for bipolar disorder because she had previous episodes plus enough manic symptoms. All right. Um, and they can have other conditions. It's not just one and done, unfortunately. So let's talk about some other conditions that can look like bipolar disorder. First one being DMDD, or disruptive mood dysregulation disorder. All right, so what is it? So these are temporary outbursts with chronic irritability. And so this is the big thing. This is chronic irritability, not episodic irritability. Um, when it was diagnosed, it was kind of a controversial diagnosis. They had really thought that this was going to be the disorder that presents in adolescence, and then they grow into bipolar disorder. You know, and ever since, that 15 years ago, that has not proved the case. Um, so it is not, this is not a precursor disorder to bipolar disorder. The data has not supported that. Um, and so our differential when we see these kids is going to be DMDD, ADHD, ODD, but we still want to keep bipolar on the differential, right? They'll have distinct etiologies. There's different neurobiology, developmental outcomes, but they all have an irritability component in outbursts, right? So they do have some common themes. All right, so here's the criteria for disruptive mood dysregulation disorder. Severe recurrent temper outbursts manifested verbally or behaviorally. All right, that are grossly out of proportion to the intensity of the provocation. All right, they're inconsistent with the developmental level. That's another key feature of DMDD. Um, they occur on average 3 or more times per week. All right, so it's not this switching between irritability and depression and things like that. So it's this chronic thing. The mood between temper outbursts remains persistently irritable and angry for most of the day, nearly every day. All right. So these are the chronically irritable kids with outbursts. All right. Um, and skipping down to G. So it should not be made before ages 6 and after age 18. So it has to be made in that window. All right. Oh, sorry. And I kind of skipped over F. That's in more than one setting. So 3 settings at home, school, with peers. All right. So it's not just limited to at home. If it's just happening at home, then we gotta look at something else, more likely ODD, right? Um, so this is chronic and across multiple settings. All right. They have to meet criteria, like I said, within a specific age range. The A3 has to be before 10, but overall it does have to occur before, some of that has to occur before 8 years of age, or sorry, 6 years of age. There's never been a distinct period lasting more than one day in which the full symptoms criteria are met for mania or hypomania. All right. Um, and it cannot occur exclusively during an episode of major depressive disorder as well. All right. These symptoms are not attributed to a physiological or substance use or medical or neurological condition. And the big thing to note is this cannot coexist with ODD, intermittent explosive disorder, or bipolar disorder. All right. So these are contradictory to the other one. You can't have one and have the other. Okay. All right. What about their course and outcome? So they're going to have an increased risk for depressive disorders and ADHD. It is very comorbid ADHD and DMDD, but that puts them at a higher risk for depressive disorders as well, or other disruptive behavior disorders. They're going to have problems, long-term problems with peer relationships, which can lead to exclusion and victimization, or aggression in relationships. Um, Adolescents diagnosed have a risk of serious mental illness, sexually transmitted diseases, um, non-substance related psychiatric disorders, nicotine use, more likely to have police contact, more likely to have poverty, and not achieving high school diploma or not attending college. And once again, disruptive mood dysregulation disorders does not show a later increased risk for bipolar disorder. All right, just an increased risk for depressive disorders. So once again, this is all centered around this irritability and temper outbursts are common to DMDD, oppositional defiant disorder, ADHD, and cognitive disorder, and bipolar. So and as we've seen, there's been an overdiagnosis of a bipolar disorder in the U.S. In this period of 1993 to 2003, it almost doubled in adults, increased 40 times in people under 20 years old. So we got a lot of people being misdiagnosed with bipolar disorder that were more likely disruptive mood dysregulation disorder. Because you have to have those distinct episodes of mania or hypomania, right? Not just this chronic irritability. All right, so here's a good chart comparing the two. So irritability is going to be chronic in disruptive mood dysregulation disorder, episodic in bipolar. When is the onset? Before adulthood. Bipolar can be at any age, but typically is an adult onset. Psychotic symptoms are very rare in disruptive mood dysregulation, can frequently happen in a manic episode. Comorbid conditions in EMDD, you're going to get depression and ADHD, and bipolar is going to be substance use. Their prognosis, so their chronic irritability plus depression, and bipolar is a chronic disorder as well. What is the specific symptoms? Mostly just outbursts. But bipolar mania, you're getting grandiosity, increased risk taking, decreased need for sleep, and the things that you're not seeing, right, in a typical person. All right, so as we can tell, there's a lot of overlap in symptoms. Look at this restlessness. You know, you get restlessness in ADHD, GAD, mania, depression, and traumatic brain injury, poor concentration, and all of them, right? Increased motor activity and all but depression, right? Distractibility, once again, all of them. Irritability, even though I said it, sorry, this isn't 100% accurate. So you can get irritability in ADHD. It's usually just not as frequent and chronic. All right, but you can in these other things, right? So this is such an overlap of the systems that can be a very confusing diagnosis. All right, let's talk about ADHD now. So the population prevalence rates have been pretty stable. It's about almost 6%. For ADHD, bipolar is still around that 2.5%. Now the risk for bipolar disorder and ADHD is about a 6 to 10% chance, or 2 to 6 times higher if you have ADHD. Okay. But the other way around, the comorbidity of ADHD, if you have a diagnosis of bipolar, is about 43%. So it's a much bigger chance of having comorbid ADHD than it is the flip or the inverse. All right. So if bipolar diagnosis diagnosed in childhood, then the rate of ADHD jumps up 73 to 90%. So begs the question, is it really bipolar disorder or is it untreated ADHD? So you got to go back to the diagnosis and really get a good history about these potential manic episodes, depressive episodes, and such, okay? Because here is a good graph or a good, can't remember what these things are called off the top of my head, overlap of ADHD and bipolar. As you can see, there's a lot of common features, all right? So they can have hyperactivity, impulse control. Of course, they're going to have attention and concentration issues. They're going to be a little bit more risk taking. Um, Usually they're just and their sleep problems are normally for ADHD is normally going to be initial falling asleep, but not necessarily decreased need for sleep like you would see in bipolar. They both have higher rates of substance abuse. Um, these are executive functioning difficulties, emotional regulation difficulties. But remember, this emotional regulation is going to be ADHD is going to be more reactive, and bipolar is going to be persistent throughout that episode. All right. So, and this hyper focus that you can get for ADHD is usually pretty short-lived in ADHD, but can be very, very, it's only during that episode, right? That you're having all the other symptoms that you get this hyper focus in bipolar. Here's another graph, so elevated mood, bipolar that's gonna be a very diagnostic for bipolar as opposed to ADHD, grandiosity, five ideas, sleep, decrease in sleep, and hypersexuality. So all these are gonna be much more elevated, much more common in bipolar than ADHD. All right. In most cases of ADHD and bipolar, differential diagnosis is complicated, and they can't have co-occurring, and these are very complex conditions. In most uncomplicated cases, the discrete appearance of the prominent mood, sleep, and aggressive behaviors are more likely to predict bipolar disorder, especially if the impulsive behavior is exhibited around money, sex, substance abuse. All right. So, um, We've all seen the typical ADHD impulsivity, just kind of not thinking through consequences. Um, there's not necessarily about spending money, about sex or substance abuse. Um, on the other hand, fidgety, restlessness, and disorganized performances that stem from inattentive and distractibility and forgetfulness, that often points to ADHD. All right. So just some little kind of some key points about differentiating between the two. All right. What about oppositional defiant disorder? This is a pattern of angry, irritable mood, argumentative, defiant behavior, or vindictiveness that lasts at least 6 months, evidenced by at least four symptoms in these three categories. Okay, exhibited during exhibited during interaction with at least one individual who is not a sibling. All right, so they have to have an angry, irritable mood. That is often. They lose their temper. They're touchy, easily annoyed, angry, resentful. They're argumentative. They with authority figures. Um, they actively defy or refuse to comply with requests from authority figures or rules. They deliberately annoy others. They blame others for their mistakes, and they can even have vindictiveness. So this is all chronic. This is what's been going on for a long time. Like it says, at least 6 months, not episodic like you'll see in mania. So you can have a lot of these symptoms in mania, but it's going to be an episode. Then they'll have a period without it, and then it can come back, right? With ODD this is a longer, has to be chronic in nature, right? At least 6 months without a significant period of lack of symptoms either, right? So if they only went a couple months, you know, they could have more later as well, but it has to be at least 6 months, all right? This is associated with distress in the individual and others in their immediate social context, like family, group, peer, work, and it impacts negatively on their social, education, occupational, or other areas of functioning. All right. But they do not occur exclusively during a psychotic or a substance abuse or depressive episode or a bipolar episode. All right. And they cannot meet criteria for disruptive mood dysregulation disorder. Once again, I said earlier, it has to be um, if they meet criteria for disruptive mood dysregulation disorder, that supersedes oppositional defiant disorder. Another way to think of it is it's ODD is as common as this chronic irritability with defined rules, um, but in between they are just fine, right? They're not always irritable. They're just easily irritable by these specific people, right? They'll say their mood, and they can when they're left alone, their mood is going to be happy, content, just fine. And that's the difference with disruptive mood disorder. They are chronically irritable. All right, that supersedes ODD. All right, what about trauma? How does trauma play into this? All right. So when I first was doing searches, I got on PubMed and Google Scholar, and look, this is showing the 5 through 10 top articles. When I just searched childhood bipolar disorder, these is what I got. This was all in the top 10. All right. This is PubMed I'm showing, but it looked very similar in Google Scholar. Um, so the trauma has a lot to do with mood disorders. All right. And so how do you tell, that we have, um, let me go back. So I'm not going to go into any specific trauma diagnoses, but just, if there's a history of trauma, um, that may also makes me question if this is really bipolar disorder as well. A lot of people can have um, borderline personality disorder, which can also look like bipolar disorder. There's a common thing called border that it's not a true diagnosis, it's just something that somebody keyed. or coined the name border polar. Where they have borderline personality disorder has a lot of bipolar looking features, but it's all borderline personality disorder. And that's usually from a childhood abuse or trauma. So I just kind of want to make sure that if I see trauma, I'm really going to question if there's bipolar. Okay. Not that you can't have. All right. So what about how would you screen these kids? So there's a childhood mania rating scale. And it's important to get the collateral information from parents, teachers, and caregivers. So these are going to be crucial. History taking is always going to be the best. Okay. These rating scales can point us towards things, but they're never diagnostic, right? So, we really have to do a thorough job. And I know it's really hard in a busy clinic, but you want to take enough time to make sure that you know what your next step is going to be, right? All right, so what is some of the first steps? Well, psychoeducation is going to be big. It's a low percentage, so you can kind of tell parents it's a pretty low percentage chance that he has bipolar disorder, that your child has bipolar disorder. And there's many different things that can look like bipolar, and you can go into this whole thing that we just talked about, ADHD, DMDD, ODD, all these things. So you can kind of start explaining that there's many different things that can look like bipolar, but really are not. Um, and then you have to tell them, like, younger children are going to have more dysregulation, emotional dysregulation with changes in parenting, so that's going to be the primary treatment for ODD and DMDD is parenting and learning how to help the parents help their child regulate their emotions better. All right, so got to work in collaboration with teachers. We're doing Vanderbilt rating scales to make sure that ADHD is well treated. Um, we're making sure the family is dealing with these crises when they come up appropriately. Making sure the family gets the support they need through family therapy or other programs. You want to make sure that they're identifying what are the triggers and the stressors that are leading to things. A lot of things, educating the parents and teaching them. Um, we don't really have a lot of trials as far as treatment for bipolar in children that correlate to clinical practice. So we don't have a lot of great guidelines for treating childhood bipolar disorder, just because it's pretty rare. All right, so we're going to want to send them to therapy, right? Some cognitive behavioral therapy. If there's a lot of emotional dysregulation and disruptive behaviors, we want a more family-focused therapy style. But there are lots of treatments out there to help these type of kiddos, all right? So there's psychotherapeutic interventions that we want to make sure you have appropriate referrals and resources for, right? Make sure you know where to send the kids. All right, what about lifestyle education, right? So the role of sleep hygiene is super important. Um, Speaking, if they do have a true bipolar disorder, they really want to be on top of their sleep routines. They want to make sure they get good quality sleep, and that's done through sleep hygiene, regular exercise, and minimizing stressors. And then educating the families about if it really is bipolar, it's going to be long-term thing. They need to stay on their medications and in treatment. Make sure they have safety plans because of the suicidality components. So make sure that you're giving the family lots of good education. All right, what can you recommend for the parents? Here are some books. The Explosive Child is probably the most common one for aggression and outbursts. Defiance, we have Your Defiant Child. We also have, more gentle ways to discipline instead of also being a hostile or aggressive parent, when we're to help the parents not be as reactive to the child's outbursts. So there's several good books that you can recommend to your parents so that they have some tools in their arsenal as well of how to deal with these behavioral problems. that may or may not be bipolar. Most likely not, right? That's kind of the whole point is there's lots of other things that are or look like bipolar that are not. So how, if you want a clear diagnosis, you want help understanding it, that's where CPAN comes in. That's why we're giving this presentation. So there's always a child psychiatrist available to talk to you throughout the day. Um, so you call your CPAN. If you're up in my region, you're going to do the options 1 and 3. If you're down in the Galveston region, then it's going to be options 2 and then 3. All right. And you can always text, right? Those are different numbers. Um, so we can help with diagnostic clarity. What treatment should be the next treatment? Sometimes we can help you decide if they need to go into inpatient care or not, or if maybe, hey, this might be better served at an intensive outpatient level. And then we can also do the one-time direct consults, and those are usually done in about 2 weeks. Okay, as long as usually the limiting factor is the parents getting the paperwork in. Okay. So CPAN is not a crisis line. If you do need crisis services, you dial 988. Okay. Or get a hold of your local mental health authority who has a crisis assessment team. So CPAN, we are here to help you. We can help you clarify between diagnoses. We can see the patient one time if you need us to. We can help you decide what is the best care, all these things. So please contact us earlier, better, right? That was the thing that I want to say I learned in emergency medicine is early intervention is always the best. And that holds true for every condition, right? Whether this is high blood pressure, whether this is depression or bipolar or ADHD, earlier the treatment, the better. And these are my references. Like I said, I know I talked about NMIH. Dr. Berkeley he has a YouTube channel and he has these online lectures and they're free on YouTube. So if you want to learn more specifics about ADHD, ODD, and their treatments he's a psychologist, he's a PhD, a psychiatrist, so he will give you all the more psychoeducation education. All right. All right. That was it. I thought I had a funny thing about questions, but maybe the state took those out. All right, so
Questions
I'm
in here,
open for
Dr.
questions.
Blood. Yeah, there was a question about how do you distinguish agoraphobia from ODD?
Agoraphobia. So agoraphobia is this fear of wanting to of a place or leaving a place. So remember, so ODD is going to be across multiple settings. They're going to be defiant with teachers. They're going to be defiant with other adults, and not necessarily centered around the leaving or going to that one place. So you have to kind of understand where the fear is coming from, or they just don't want to do what the parent is telling them, like leave the house, right?
Dr. Blood, there's so much of what you talked about has overlap. And I can see as a primary care provider that has limited time seeing their young patients, that it could be somewhat challenging to diagnose the child. So one of the things that providers on the call may or may not be familiar with is the way that we can actually do that diagnosis for them through that direct consultation. That's available throughout the state of Texas. So let's say I'm a primary care provider and I've got all these different symptoms and I can't tease it apart. How would I go about having CPAN help me with that?
I'll just give an example from this morning. A provider called. The kid had actually already been to a psychologist for testing, so they got some clarification. Yes, he does have ADHD. Um, you start on ADHD treatment, really didn't resolve all of his symptoms. They're like, what do we do now? Like, I kind of think he might have autism, but they ruled it out. the ADOS was a score of 3, so he definitely had symptoms, but not enough symptoms to meet criteria. What do we do now? All right, they titrated up. He was on Quilivant, titrated that dose up. What's the next step? Like they were lost. I'm like, all right, we'll just do a drug consult. We'll see the kids ourselves. We'll be able to we'll do our full psychiatric evaluation to kind of go through all the different common conditions in childhood. We'll go more in depth and to make sure that the ADHD treatment that is the best choice for his ADHD. Get a good history, and then we'll be able to give a full assessment and recommendations after we see the kiddo.
So that's available across the state of Texas. That's available through all the 12 hubs. If you're a primary care provider here working with patients under age 23, all you have to do is contact your CPAN hub, have a brief conversation with one of the child psychiatrists, and let them know that you're interested in that. We don't say no. Because we know that there's limited support and services. Now, Dr. Edom had a question about antipsychotic meds.
Yeah, I see that. So under 15 years old. So 2 of them are FDA approved for children and adolescent with aggression and autism. So yes, FDA approval for that specific scenario under 15 years of age. However, we also do use them off-label, right? We can really use anything off-label. All right, I use clonidine off-label all the time to help people sleep, right? It's FDA approval. So yes, you can. It may not be in its FDA approval, age range, or otherwise. But so we do use atypical antipsychotics under age 15 for this irritability and aggression.
If you want to, talk more about that specifically about that patient,
right? Yeah,
that's
if you ever
certainly,
want to know what about with this kiddo, that's when you would need to call and have that discussion with the CPAN provider. They can
those
maybe help you choose
conversations.
one versus the other, or maybe this is more something else.
And those consults on the phone with you, those initial consults, Dr. Blood, are fairly short, but they can be as long as that primary care provider wants to chat with you, right?
Yeah, typically, I say they're usually less than 10 minutes, but I've had some go longer. Had some that are all within almost 20 minutes. That's if the doctors or the providers have enough time for that. I know clinic can be busy, so you can always schedule them for lunchtime, or you have an administrative time during the day or whatever.
So there was a great question from Alyssa on here. It says, is this available to the general public and only providers? This is really, the way the legislation is written is this is for primary care providers. However, the families can reach out to their primary care provider if they have a patient under age 23 and have that primary care provider reach out to the CPAN hub that is in their region. There are 12 of us across the state of Texas. What other questions? We have 7 minutes still left. We can play Stump the Psychiatrist. So if you are on the call here today and you would like to have a psychiatrist come and speak at your clinic, we in Northeast Texas have something called a CAP roundtable where we will bring a psychiatrist with us to your office. This often happens over the lunch hour, which tends to be the most convenient for clinics, and have conversations about child psychiatry, talk about different medications, different situations that you have run into at your clinic, and how we can best serve you as a resource for child and adolescent psychiatry. Best practices for using services and how to use our direct consultation availability as well. Those are at no cost for your patient. and your clinic and their insurance. So there's nothing that costs anybody during that direct consultation option. Something that is coming soon this summer is we will have a PCP portal that'll be going live. We're in the process of testing that now so that primary care providers can use that service. More will come, and your hubs will be reaching back out to you. So what other questions? Does Access in Jacksonville have face-to-face or telehealth options for our community? Dr. Edom, I don't know what Access has. To be really be real frank with you, I don't know, but I can tell you that we have the direct consults are through video that we do, and we can get them done in less than 2 weeks. Sometimes the parents are right on it and get the paperwork done, and we've had them done in less than a week. Is there something else that we can answer today? Yes, ma'am, or you can text us. You are already signed up. I will give you the texting number here.
Yeah, we have a texting AI bot named Mike. He's really good about texting back quickly.
Yeah, and we make sure that everybody knows he's not a bot, because even though he has a 5-minute metric to return those texts, he answers in about 15 seconds. Right,
Look,
Mike
he
is
already, he
not a
already
bot.
responded, see?
See, there you go. So, and those who do text us, we have a little something that we send you as a special thank you for using our texting line. And to hear from you, Dr. And we're also trying to come to the Jacksonville clinic. So that hopefully is going to happen soon. I've been talking with Susan Campbell about that. All right. I don't see any other questions, Dr. Blood. So I do want to let folks know next month on the 27th of May, we have another CPAN CME. We are going to be reprising the Click Here, How Internet Use and Social Media Affect Children's Mental Health. That will be presented by Dr. Stephanie Simmons. She is one of our child psychology faculty here at the university. This is an amazing session. This is probably the 3rd year we've done this one, because social media and internet has been has had such an impact on our youth and our adolescents. And this is a topic that's been really well received over the years. So we hope that you join us for that. If you have any questions or you want a copy of this session, I can send you a PDF copy of that. I'll put the email address for CPAN in here. And all you have to do is ask for a copy of today's session. If you are not enrolled with CPAN, we encourage you to do that. If you work with patients, if you're family medicine and work with patients, I can't walk and chew gum. Let me type this in here real quick. That are either preconceptual, pregnant, or postpartum up to 1 year, we have something called PeriPan. PeriPan has not child psychiatrists, but reproductive psychiatrists. And didn't know if you knew there was a reproductive psychiatrist, but there are, and they work with those women in the reproductive years. And so if you've got patients that you're seeing that are pregnant up through pregnant or postpartum up through 1 year, even through a postpartum loss, you can contact us and we will get you hooked up with a reproductive psychiatrist. Thanks, Dr. Singh. We love serving you, and it has been our distinct pleasure to serve you in the Canton Clinic. Thank you so much. And PeriPan is growing. quite significantly. These reproductive psychiatrists will walk you through some of the areas that may be a little uncomfortable for you in working with a woman who may be pregnant but has mental health needs. And they can also do a direct consultation through video. We have no reproductive psychiatrists in Northeast Texas practicing at this time. And so what we want to do is make sure that those women with mental health needs are healthy throughout their pregnancy and postpartum, and not just take them off their medication, but make sure that they are getting the right type of mental health treatment throughout their pregnancy and postpartum period. So you can give us a call with that. It's the same phone number. That's the same texting line. You can text Mike here in Northeast Texas at that number if you want to talk about a woman that is pregnant or postpartum, if you want to talk about a patient that's under age 23, parents struggling with parenting, you can reach out to us. We'll help you with the resources and referrals on that. So it is top of the hour. I am going to go ahead and stop our session recording now. And this will be uploaded to our YouTube page later today. I'll stay on here if you have any additional questions.